Okay, good afternoon. I'm Jae-Joong Kim, and as my co-chairperson is Junya Ako, Kitasato University, Japan. I'm working as a medical center, Korea. This session is interventional heart failure treatment session, and this session consists of 6 topics. And this session will cover MCS Impella and Interatrial treatment for heart failure and surgical and non-surgical treatment of ischemic cardiomyopathy. After completion of all 6 topics, we will have a panel discussion and from 8 panelists and question and answers from the floor. I would like to introduce the first speaker, Junya Ako, Kitasato University School of Medicine, Japan, and his topic is real-world experience with the Impella use in Japan. Please.
Thank you very much, Dr. Kim. I'll talk about real-world experience with Impella use in Japan. So this is my disclosure. AMI with cardiogenic shock is associated with very high mortality, and the mortality hasn't changed for a long time. So this is data from Ontario showing that there's almost no or minimum improvement in survival rate from 2009 through 2019. Previous trial with circulatory support with IABP shock trial showed no difference in mortality. And also, use of ECMO in ECLS shock trial showed no benefit in survival. However, now we have danger shock trial, which showed that almost 12% benefit of mortality benefit with the staggering NNT of 8. Of course, the eligibility criteria for danger shock was somewhat narrow, but they carefully selected the patient with STEMI and with the evidence of peripheral hypoperfusion and LV dominant heart failure, and not to sick patients, and no other morbidity patients are included with short onset to unload patients. Danger shock trial has shown that this therapy with Impella comes with a price. It's associated with high bleeding risk and renal replacement therapy. But in patients who received temporary renal replacement therapy, the patients still show mortality benefit with the use of this Impella microcirculatory support. Now I'll show you some of the data from Japan. In Japan, every patient who received Impella has to go through this JPVAD registry. Now we have more than 10,000 patients registered in this registry. I'll show some of the data from this registry. This is a real-world indication of Impella. More than half, about 56% of the patients who received Impella, the indication was cardiogenic shock with myocardial infarction. So this is the initial data which I presented several years ago. This is a 30-day survival of AMI cardiogenic shock patients. So in patients who received Impella alone, the 30-day mortality of AMI cardiogenic shock was 80% in this registry. For those patients who received Impella, it was still low, about 45%. But in patients with Impella alone, it was associated with very high survival rate. In this registry, the shock diagnosis to Impella less than 6 hours associated with better survival, which showed that early use of Impella may be associated with better survival. So currently, ACC/AHA SKY guidelines for ACS downgraded the use of IABP and LV assist device to class 3. Routine use is not indicated. However, now they have class 2A indication of microaxial intravascular flow pump, which in Japan only Impella is available. So let me skip through this. So this is a clinical guideline in Japan, the use of PCPS, ECMO, and Impella. So for those patients with cardiogenic shock, use of MCS, including Impella, indicated in patients, even in patients with SCAI B. And for patients with SCAI C or D, very detailed use of Impella shown, recommended in these guidelines. What's the real-world use of MCS in Japan? This is a Japanese nationwide cohort, and those patients who received mechanical circulatory support, the use of IABP is declining. And now we see, so in Japan, 2017, Impella was approved for clinical use. And so this is PVAD, ECMO plus PVAD or PVAD alone right here. So we are seeing more and more patients receiving Impella. So this is patients who received PCI for the treatment of acute myocardial infarction. About 12% of the patients associated with cardiogenic shock in patients with acute myocardial infarction. And we are seeing increasingly, we are seeing this green is Impella. We are seeing more and more patients treated with Impella in patients with acute myocardial infarction. So let me conclude. MI cardiogenic shock is associated with very poor clinical outcomes. Danger shock randomized trial has shown mortality benefit with Impella in MI cardiogenic shock patients. JPVAD registry has shown excellent results of Impella in a real-world setting. And we are seeing increased use of Impella in Japan. Thank you very much for your attention.
Thank you. And the second speaker is Gregg Stone, and Mount Sinai, USA, and his topic today is Interatrial Shunt treatment for heart failure.
Well, thank you very much. So the background for considering creating a small interatrial shunt in heart failure is that both heart failure with reduced and preserved ejection fraction are characterized by increased left atrial pressure and pulmonary venous congestion, and that left atrial pressure rises with exercise and with fluid overload and may be difficult to regulate pharmacologically. So a small interatrial shunt may provide an autoregulatory mechanism to decrease left atrial pressure and improve heart failure symptoms and prognosis. And by autoregulatory, we mean that it is there, it works 24 hours a day, 7 days a week, and as the left atrial pressure increases, for example, after a fluid bolus or with exercise, the gradient between the left atrial and the right atrial pressure increases, so the cardiac output flow from the left side to the right side of the heart increases, further reducing the left atrial pressure. Now, to date, we've had 2 pivotal randomized trials of creation of a small interatrial shunt. The reduced LAP HF2 trial in heart failure with preserved ejection fraction, that was a negative trial. And the Relieve HF trial in HFrEF and HFpEF was also a negative trial. But there's still a lot of excitement in this field. So why is that? Well, let's step back. Here's the approximate 7 shunts that have been most widely used in patients. And what you can see is they all look a little bit different, but there are a few characteristics that they have. 3 of them are permanent implants from the left atrium to the right atrium. The 4th one's a permanent implant from the left atrium to the coronary sinus. And then there are 3 shunts from the left to the right atrium that are basically just coring out tissue with radio frequency or mechanical energy and leaving a hole behind, but no permanent implant to keep the hole open. You can see the shunt sizes range from anywhere from about 4 millimeters to about 12 millimeters, and this will impact the pressure change that is experienced with exercise or fluid overload. And you can see the pivotal studies that have been done. So let's start with reduced lap HF2. This was a 626 patient sham-controlled randomized trial in HFpEF, LVEF greater than 40%. They had to have an exercise-induced wedge pressure of greater than 25 millimeters of mercury. And they're randomized to the Corvia 8 millimeter shunt versus control. They excluded patients with severe increase in pulmonary vascular resistance and moderate or greater RV dysfunction or tricuspid regurgitation. And the primary endpoint was a so-called hierarchical win ratio composite of cardiovascular death or ischemic stroke at 1 year, total heart failure-related hospitalization and other events up to 2 years, and a change in KCCQ representing heart failure-related quality of life at 1 year. And there was absolutely no difference between the two groups. And here are some of the individual event rates. You can see the death rates in HFpEF are extremely low. The stroke rates were very, very low. Most of the events were heart failure-related events, about 1 out of 4 patients per year being hospitalized or having another event. And you can see all the patients pretty much felt better. There's a 10-point change in KCCQ. That's why placebo-controlled trials are so important, and no between-group differences. There was some safety concerns. Overall, the shunt's a pretty easy procedure and was overall safe, so the primary composite safety endpoint was negative. But when they looked at what they called MACE, there were a slight increase in MACE events, mostly due to an increase in number of myocardial infarctions, from 5 to 1. Those could have been embolic myocardial infarctions, or this could have been play of chance. Now, they did a pre-specified and post-hoc subgroup analysis to see if they could determine a subgroup that benefited. And they found that there was one very important post-hoc subgroup, and that was whether or not the patients had a peak exercise pulmonary vascular resistance of above or below 1.74 Wood units. That means, was there so much pulmonary hypertension that the pulmonary vasculature could not vasodilate during exercise? And if there was so-called fixed or latent pulmonary vascular disease, those patients did worse. They also found not having a pacemaker or an ICD lead was also of benefit, but it was really this latent pulmonary vascular disease that was the most important parameter. And if they took patients without latent PVD and with no pacemaker, then the win ratio was positive, heart failure events were decreased, and the KCCQ score increased. On contrast, if they took patients with latent PVD, the exact opposite was noted. So here are just the heart failure-related events in the so-called responders, a 50% reduction in heart failure events. In the non-responders, more than a 100% increase in heart failure events. Now, on the background of this, we were running for many years the RELIEVE-HF trial. This was also a sham-controlled, blinded, randomized trial, but in this trial, we enrolled all patients regardless of ejection fraction, from 0% to 100%, so both HFrEF and HFpEF. And we randomized about 508 patients, but we didn't know if the results would be the same in HFrEF and HFpEF, so we actually stratified the randomization according to HFrEF and HFpEF to the Ventura atrial shunt versus a placebo procedure. And first of all, regarding safety, this was an extremely safe procedure. We had a primary safety endpoint of major adverse cardiovascular or neurologic events, and there were none. 0 patients at 30 days had such an event, and in fact, 0 patients at 2 years had such an event. So very safe procedure. But there was no efficacy. When we looked at the composite of death, LVAD, transplant, heart failure events, exactly the same rate in both arms. But where it got interesting was when we looked at HFrEF versus HFpEF. There was a marked difference in response to the shunt in our pre-stratified subgroup. In patients with left ventricular ejection fractions less than or equal to 40%, there was more than a 50% reduction in adverse events. Whereas in the HFpEF group, there was a 68% increase in events. When you looked at the kind of events, in the ejection fraction less than 40% group, all the components of these heart failure-related events were reduced. In particular, LVAD and heart transplant, there was about an 84% reduction. All heart failure hospitalizations, a 48% reduction. In contrast, in the patients with preserved ejection fraction, they had a tripling of mortality and a doubling of heart failure hospitalizations. Now, why should that be the case? Both syndromes are characterized by increased left atrial pressure, but the cardiac structure and function are very different in HFrEF and HFpEF, which may determine whether or not you can accommodate an increased cardiac output from the left to the right heart. In HFrEF, the ventricles are thin-walled, they're dilated, they're very compliant. And so the theory goes you can accommodate blood flow from the left to the right because of this. In contrast, in HFpEF, the ventricles tend to be thick, they tend to be normal size, or even the cavities are somewhat smaller, and as you increase blood flow from the left to the right heart, the pulmonary pressures go up as a response because the right ventricle can't accommodate that extra blood flow. So, what happened after these trials? Well, V-Wave has submitted the HFrEF data to the FDA, and that's being considered for a HFrEF indication. Corvia is designed a second trial called Responder HF in that positive subgroup that I described to you. Alleviant, which is one of the companies that leaves nothing behind, is enrolling in 2 randomized trials. First, a trial called Allay HF, which is very similar to Responder HF, and now they're also enrolling in Allay HFrEF, which is very similar to the HFrEF population in the V-Wave trial. And there was a 4th program which is now on pause. So this is the Responder HF trial. It's 260 randomized patients to confirm that subgroup that I showed you from the Corvia study. It's using a Bayesian borrowing design, and it's just HFpEF patients without latent pulmonary vascular disease and without a pacemaker lead or a CRT lead. Allay HF is a very similar patient population. I won't go through the details. This is a larger trial, 400 to 700 patients, because it is standalone, although it's got an adaptive and Bayesian design. And I'm also involved in running the Allay HFrEF trial as well. This is 350 patients where we're looking at recurrent heart failure-related events with a very similar enrollment criteria as to the HFrEF population of the Relieve HF trial with V-Wave, but some slight differences. So, in summary, an intratracheal shunt may provide an autoregulatory mechanism to decrease left atrial pressure and improve heart failure symptoms and prognosis. Although 2 completed randomized pivotal trials have been negative, there's strong evidence that the 5.1 millimeter V-Wave Ventura atrial shunt is beneficial in HFrEF. That was a stratified, pre-specified subgroup analysis. And the 8 millimeter Corvia interatrial shunt device may be beneficial in selected patients with HFpEF without latent pulmonary vascular disease. 3 ongoing pivotal randomized trials will provide confirmatory data in patients with HFrEF and the HFpEF responder group. And those studies are ongoing and hopefully will report out within about 2 years. Thanks very much.
Thank you. The next speaker is David Paul Taggart, is University of Oxford, United Kingdom. His topic is CABG in patient with impaired ventricular function, indications and outcomes.
Thank you, Mr. Chairman. It's a great pleasure to be here at the 30th anniversary of TCTAP, so I feel very privileged to give this talk. I'm going to talk about CABG in patients with impaired ventricular function, but point out not those who require advanced mechanical circulatory support. I don't have any relevant conflicts of interest for this presentation. Just to give a perspective of where we are, if you look at ischemic cardiomyopathy, defined as an ejection fraction of below 35%, with or without heart failure, globally there are 125 million people with ischemic heart disease. In the USA, almost 750,000 diagnoses of new myocardial infarction each year. Of these, 35% of patients will die as a consequence of that, with an average loss of life expectancy of 16 years. There are now over 6 million patients with heart failure in the USA, and ischemic cardiomyopathy is the largest cost. In terms of economic outlay, It costs over $40 billion annually. And in the USA, there are currently around 350,000 CABGs per year. But if you scale that number up, another 350,000 over all of Europe, and worldwide, somewhere about 1 million CABGs. If we look at CABG in patients with ejection fractions below 35%, excluding the need for formal advanced mechanical circulatory support, this is currently around 5% of patients, up to 20% of patients in some studies, but the numbers of these patients is certainly increasing. Now, the study with which we're all familiar, which supports the use of CABG in patients with ischemic cardiomyopathy, is a STITCH trial extending out to over 10 years, so basically a randomization of over 1,200 patients to either medical therapy or CABG. And even although around 20% of medical therapy patients crossed to CABG, CABG still had a survival advantage. It appeared around 5 years and continued to advance and accelerate out past 10 years. And this was also true for deaths from cardiovascular causes, and it was particularly relevant in patients with 3-vessel coronary artery disease. So if we go back to 2017 and look at what was a conventional therapy in terms of patients with heart failure, there were 21 studies in this meta-analysis of over 16,000 patients with ejection fractions below 40% who underwent medical therapy alone, those who also had PCI, or those who had CABG. At a median follow-up of 3 years, so relatively short-term follow-up compared to most major trials, in terms of CABG versus medical therapy, there's a very significant reduction in the hazard ratio for survival in favor of CABG, accompanied by reduction in myocardial infarction and the need for repeat revascularization. A similar but smaller benefit was seen in patients undergoing PCI. And if you compare CABG to PCI, the hazard ratio was strongly in favor of CABG. This is a more contemporary study by Mark Roell's group in Ontario, in Canada. They looked at almost 5,000 patients undergoing PCI or CABG with ejection fractions below 35%. And these patients, although not randomized, were matched for 30 baseline characteristics. And what you can see is that CABG resulted in a marked improvement in survival and accompanied by a marked reduction in MACE, myocardial infarction, the need for repeat revascularization, and no difference in the risk of stroke. If you look at another registry study looking at patients with left ventricular impairment as well as diabetes, you can see in the first of these slides, these were in patients with an ejection fraction of 35 to 49%. The number was around 1,000 patients, and roughly half had PCI and roughly half had CABG. And you can see that CABG resulted in a marked reduction in death, almost for myocardial infarction, and the need for repeat revascularization, and no difference in the risk of stroke. And when you look at this for patients who had further reduced ejection fractions, again, CABG showed significant improvements in survival, accompanied by marked reductions in myocardial infarction and need for repeat revascularization. Now, the hypothesis that PCI would achieve the same effects as CABG was tried in the REVIVE trial. This was a study in the UK of 700 patients with ejection fraction below 35, randomized to either optimal medical therapy with PCI or optimal medical therapy alone, and followed for almost 4 years. And you can see that at the outcome, there was no differences in the composite primary outcome, the secondary outcome, the risk of death, myocardial infarction, hospitalization, or the need for repeat revascularization. So this trial showed conclusively that there was no benefit of PCI in patients with ischemic LV dysfunction, in contrast to what the STITCH trial had shown. So where are we today? The American Association of Thoracic Surgery have provided pretty extensive guidelines in the way to consider treating patients, and I won't go into the cardiac surgery details, but I will make one general comment. Their recommendation was that preoperative optimization of patients by a heart failure team is vital. So if you want to get the best outcomes in patients with heart failure undergoing CABG, these patients need to be treated by specialist heart teams. Finally, I'll finish with this slide. What about inducible myocardial ischemia? This was proven in the ischemia testing in the STITCH trial, so not the current ischemia trial, and around 1/3 of patients underwent ischemia testing, of whom 2/3 is inducible ischemia. And the authors concluded in coronary artery disease with severe LV dysfunction, inducible myocardial ischemia does not identify patients with worse prognosis or those with greater benefit from CABG over optimal medical therapy. And similarly, if we look at viability testing, this was performed in around half the patients in the STITCH trial. And when you looked at survival for CABG plus medical therapy versus medical therapy alone, the authors concluded no significant interaction was observed between the presence or absence of myocardial viability and the beneficial effect of CABG. So why are these findings important? They're very important clinically because it means that if a patient has severe angiographic disease accompanied by impaired LV function, you should not deny a patient the prospect of CABG either on ischemia or viability testing. And finally, I'm going to conclude by recommending this book, edited by myself and my good friend and colleague in North America, John Puskis, State-of-the-Art Surgical Coronary Revascularization. So this has 72 chapters, and of course you say, how can you write 72 chapters on CABG? But we did. Well, not personally, but we edited 72 chapters, and it covers every aspect of preoperative, intraoperative, and postoperative management of patients undergoing coronary revascularization. On that point, I will conclude my talk. I would like to again thank the organizers, especially Dr. SJ and Duckboo Park, for the invitation to be here on the 30th anniversary celebration of TCTAP. Thank you.
Thank you very much. So we move on to the PCI in ischemic cardiomyopathy. Dr. Lee, please.
Well, it's very hard to talk about PCI after Professor Taggart, wonderful lecture. But I'm going to talk about the current contemporary revascularization in ischemic cardiomyopathy. These are my disclosure. As Professor Taggart mentioned about the STITCH trial, and actually the best medical treatment with using ARNI and the bypass surgery, they proved their survival benefit over conventional medical treatment. However, the revived trial totally failed to show any difference in terms of mortality or heart failure admission between PCI and optimal medical treatment. To me, it is very hard to understand what is so different in this PCI compared with the bypass surgery. Anyway, those two modalities are revascularization. So I became to think about the coronary revascularization by PCI can be different according to the following factors: the duration of myocardial ischemia and the reversible myocardium, especially about the underlying microvascular circulation and how myocardial ischemia was diagnosed and the concept of revascularization. And if we are doing PCI, the local severity and distribution is very important for the PCI's effect, and the lastly, procedural optimization is much more important. So the first factor, duration of myocardial ischemia, the left gentleman, VP cardiac arrest because of acute myocardial infarction, and right patient failed thrombolysis 20 years ago And since then, he has been living with the ejection fraction 27% and the heart failure symptom. So coronary disease, the left patient, triple vessel disease with distal left main bifurcation, and right patient, proximal LAD CTO. Anyway, both patients were successfully revascularized. The left patient on the ECMO and the complex 2 stenting for the left main, the right patient, simple LAD CTO PCI. 6 months later, left patient fully recovered his left ventricular function. However, right patient, no change at all. However, the symptom much improved. So duration of myocardial ischemia is very important. And if you decide to do PCI, I think it should be earlier as possible. What about underlying microcirculation? These 2 patients had an intermediate stenosis at the proximal LAD. However, in the left patient, FFR very low, so it is functionally significant. However, right patient, FFR 0.91. However, this is not the end. If we see CFR and IMR, CFR 1, IMR very much elevated up to 80 units. So final diagnosis of this patient was cardiac amyloidosis. So any coronary revascularization for this patient will be meaningless because the myocardium is already dead. And current viability testing from revived PCI's 2 trial, these results clearly showed that viability testing is not for finding the responders of PCI. It should be used to find non-responders of PCI because of the higher amount of non-viable myocardium or scarred myocardium. What about ischemia diagnosis? These non-invasive tests, we have been using these tests very frequently. However, and I think those are very good tests. However, the problem is these findings from non-invasive stress test matches with my angiographic finding only in 50% of patients. So even though we have an abnormal result in stress MR or ammonium PET or something, I cannot match those abnormality to my angiographic findings in 50% of my patient in the cath lab. So we need more higher resolution test, and I think it is invasive physiologic assessment. So if we see the ischemia trial, as you well know, all of the PCI in this trial were guided by non-invasive stress test, and it was negative result. However, if we see the patient level pooled analysis about FFR-guided PCI, death or MI were clearly better following FFR-guided PCI than medical treatment. So this means that invasive FFR with higher resolution and higher diagnostic ability is more effective than non-invasive stress test-guided PCI to reduce death or myocardial infarction. And let me show you one case example. The ejection fraction 23%, 65-year-old male. He had been treated for dilated cardiomyopathy for a long time and repeated heart failure admission. Coronary angiogram, proximal LAD intermediate stenosis, and this was judged as a non-significant coronary artery, and he had been treated by DCMP. However, FFR very, very low, and PCI successfully done, and post-PCI FFR was good. After 3 months later, the ejection fraction nearly normal. So we need a higher resolution test to better diagnosis myocardial ischemia. And what about concept of revascularization? Bypass surgery can provide the future protection for the progression of initially non-flow limiting stenosis. However, PCI is just a local treatment. That's because, so we need more procedural optimization for the stented segment and the more meticulous secondary prevention to to protect the progression of initially non-flow-limiting stenosis. So indeed, the post-PCI result, angiographic successful PCI is not same with the ischemia resolving PCI because PCI resulted in suboptimal post-PCI FFR will have higher clinical event. And why physiology-guided PCI is not same with the physiologically optimized PCI because local severity and distribution is different. These two patients have same FFR value, however, totally different pattern of disease distribution. The first patient, focal lesion, however, the second patient, diffuse lesion. This patient will have worse clinical outcome even after the angiographically successful PCI. And from my group, these two parameters, so local severity and the physiologic distribution, this 2x2 classification can classify the patient with higher clinical event even after the angiographically successful PCI. So long story in short, underlying diffuse disease is bad even after the successful PCI. And the last one is the procedural optimization. So about 2 years ago, my group presented Renovate Complex PCI trial. Image-guided procedural optimization is very important to reduce cardiac death compared with the angiography-guided PCI in patients with complex coronary artery lesion. However, revived PCI's 2 trial never mentioned about physiology-guided treatment decision and image-guided procedural optimization. So I think the PCI that used in the revived PCI's 2 trial is maybe not a state-of-the-art contemporary PCI. So we need another trial. So my group has been running this Restore PCI trial, same inclusion criteria. However, in the revascularization group, image-guided procedural optimization will be strongly recommended, and any intermediate stenosis will be evaluated by invasive physiologic index. And on top of best optimal medical treatment, we will compare this revascularization versus GDMT alone in terms of a composite of death MI, admission for heart failure, or advanced heart failure requiring LVAD or transplantation. Thank you very much for your kind attention.
Thank you very much. We'll move on to the next speaker. Management strategy for severe ischemic heart disease when CABG is not an option. Dr. Imad Sheiban from Italy.
Thank you. We know that clinical manifestation of coronary artery disease can be distinguished in stable and acute coronary syndromes. And the management basically is conservative, can be conservative, that means optimal medical therapy or revascularization, both by PCI or surgery. And key factor to be considered to guide the choice between angioplasty and surgery might be anatomical factors related to anatomy and complexity of anatomy, clinical factors, basically comorbidities, operator experience, and in both surgery and PCI. We have a lot of scores to define the risk profile of patient. And again, the revascularization, now to choose between angioplasty or surgery should depend on the discussion and evaluation of all factors indicated here. That means coronary anatomy, patient preference, surgical risk, local expertise, life expectancy, comorbidities, or risk factor control and clinical presentation. And we know that both of these modalities have pros and contras. By guidelines, again, the choice of revascularization modality is the evaluation, what we have mentioned before. That means the risk of patient, anatomy, complexity, left ventricular function, patient preference, and the outcome experience, and it is class 1. And we also know from clinical, basically from evidence-based guidelines that 3 vessel disease, that means severe coronary artery disease, is not a procedure for angioplasty, and first option should be always surgery. Like in this patient, diffuse the 3 vessel disease, high syntax score, CABG, of course, is the first option in this patient. However, the benefit of surgery in left main and multi-vessel disease decreases in frail patients with multiple comorbidities, which increase the patient's surgical risk and can negate the benefit of surgery. 1 of 5 patients with left main or multi-vessel disease is declared surgically ineligible. Management of these patients with severe ischemic heart disease is still a growing challenge. And can the potential benefit of PCI improve quality of life and survival, overcome its risks in this subpopulation? I think it is the main question when you are discussing this kind of subpopulation for revascularization. And mostly of what we have mentioned before should be considered ineligible for CABG. So this is the post population which composed what we call today complex high-risk indicated procedure by angioplasty. That means the cheap complex procedure. And this includes multi-vessel disease with distal left main and complex anatomies with bifurcation, calcification, and so on. Beside this subpopulation, we have also some conditions which might not be a good option for surgery, like diffuse and extended disease along the vessel, along the whole vessel, where it is difficult to form the anastomosis between any conduct and the vessel itself, as well as severe aortic calcification. And these patients also can be, surgery can be negated. Severe disease of subclavian artery, as well as severe peripheral artery disease, as you can see here in this figure. And in these patients, I think that with diffuse disease on coronary arteries till distal segments, I think surgery is not a good option. And we should, of course, discuss about what is the appropriate approach in this. I think that full metal jacket in these cases cannot be a good option anyway. So I think in these cases, functional evaluation and to limit the treatment only to those stenosis which are severe and important for the patient, and this can be determined by a good functional study of the artery. As you can see here, for all stenosis, only the mid-segment of LAD and the proximal segment of circumflex should be treated, because only these segments are having significant disease. And this can limit the number of stents as well. And finally, I think surgery is not a good option, of course, in patients presenting with STEMI, like in this case. And even if you have a really very severe coronary artery disease, I think these patients can be fixed and should be fixed with angioplasty, but with optimal angioplasty. That means using mechanical circulatory support, as well as all which permit also to use to optimize the procedure by intravascular guidance or functional guidance, as in this case, and come out with a really very, very good final result. And saving, of course, the patient. This patient was leaving the hospital after 5 days from this procedure. So in conclusion, I think in multivessel disease patient with high syntax score, surgery is the first option, particularly in diabetic patient, in those with left ventricular dysfunction, and with other cardiac surgery indication. Surgery is not an option in almost 20% of patients with multivessel disease and high syntax score, as well as in those with severe aortic calcification, severe peripheral artery disease, diffuse extended disease on coronary arteries, significant disease in subclavian and anonymous arteries. And in this subpopulation, angioplasty can be an acceptable alternative, particularly if guided by functional evaluation and appropriately performed with mechanical support in the presence of left ventricular dysfunction with good lesion preparation, optimization, and so on. In future perspective, also the drug-coated balloon angioplasty at mid-distal segment can be performed as a treatment modality complementary to drug-eluting stent to reduce the number and length of stented segment, waiting, of course, but we are still waiting for a good clinical data supporting this. Thank you very much for your attention.
Thank you very much. We move on to the final speaker, Controversies in Medical Therapy in Ischemic Cardiomyopathy. Dr. Jeehoon, Kang, please.
Yes, thank you for the kind introduction. On the sake of time, I think that I have to fly through my slides. And previously, we talked about CABG and PCI for ischemic cardiomyopathy, but my talk's going to be about the medical therapy of this same disease. And first of all, regarding the definition, ischemic cardiomyopathy, of course, there's ischemia in the coronary arteries, but obviously this is not the only reason that this patient, he or her, has any kind of cardiomyopathy. So we all know that ischemic cardiomyopathy is different from acute myocardial infarction. Ischemic cardiomyopathy is a complex pathophysiological situation, including metabolic, neurohormonal, and inflammatory changes. And that's why previous trials have sort of been mixed up these kinds of concepts and used different definitions, different patient populations, and made the treatment more difficult. So regarding revascularization, because it's ischemic, regarding this figure right here, we can see that there's a lot of reasons that ischemic myocardiopathy is a ICMP, but among these, only 2 of these have any kind of concept that can be resolved by any kind of revascularization. There could be a flow-limiting or non-flow-limiting stenosis, while the other factors cannot be improved by revascularization. So this is what makes ischemic cardiomyopathy very complex. So going back to revascularization, this is a concept that we have and we expect any kind of revascularization will be beneficial for the patient. The patient has a, let's say, LV dysfunction with a ischemic coronary artery disease, which might improve if the myocardium is still recoveryable. That means that if the myocardium is stunned or hibernating. So this is a conception that we do any kind of revascularization. So this was nicely shown in the STITCH and the extended trial, showing that a CABG therapy could improve the hard endpoints in the long run in those who have a LV dysfunction plus who are obviously CABG candidates. However, in this study, we could see that the survival benefit was after about 2.5 years, which is also a very interesting finding. Then what happened during the early 2.5 years? Was this the time that the myocardium had to improve after hibernating or being stunned? This can be an explanation, but still, because they have the CABG arm had a improvement in heart outcomes, we now have a guideline that recommends CABG for these patients. So okay, then, well, let's say that the myocardium has improved. Then this was also shown by the previous speaker, But however, even if the myocardium had improved, we have to have some kind of index to prove that the myocardium improved. Usually we thought that viability could explain that, but in sub-studies of the Stitches trial, we could see that viability did not have any interaction in regards of whether the patient received medical therapy or CABG. Rather, if the patient had any kind of viable myocardium, irrespective of any kind of treatment, the patient had an improvement in LVEF, while if the patient did not have any kind of viable myocardium, even if the patient received CABG, then the patient did not have an improvement in LVEF. What goes one step more complicated is that even in those who receive, even in those who have an improvement in LVEF and those who don't, there was no difference in the clinical outcomes. So this gives us a very complex kind of finding. Viability is not correlated with the revascularization process. We thought that an improvement in LVEF would be better, but that wasn't that much prominent in this study. So then what are we looking at and why are we treating ICMP? So this is a very complex issue again. As I showed you, only 2 of the factors are related with any kind of revascularizations. The others are related with, let's say, the scarred myocardium, the MR, the enlarged LA, the scarred myocardium, which can induce any kind of arrhythmia. So these points are probably more important than just giving restoration of the coronary flow. And also, we know that in traditional, classical, non-HCMP heart failure, all of the medications are focusing on metabolic or neurohormonal activities to reduce any kind of adverse events in heart failure patients. So regarding the pharmacotherapy for ICMP, there has been a lot of studies, and also we know that these medications are almost identical to those with non-ICMP heart failure patients. So it's beta blockers, AC inhibitors, ARBs, ARNIs, MRAs, and also SGLT2 inhibitors, which are not related to restoration of the coronary flow, but they control the adrenaline stimulation, reduce arrhythmia, prevent any kind of remodeling, and prevent and induce osmotic diuresis, which are related to probably beneficial outcomes in clinical outcomes and also symptoms. So I will just go through these studies really quickly. So for beta blockers, the Capricorn trial showed improvement using carvedilol. We have a lot of studies in registry studies that showed beneficial impact of beta blockers. However, a lot of RCTs have also shown that there is no impact in the usage or even discontinuation or in continuation of beta blockers. So this gives us a very confusing finding whether we should use beta blockers or not in the current patients that we treat as ICMP. Also, some analyses have shown that after the reperfusion era, the impact of beta blockers have decreased compared to the RCTs that have done before this era. Regarding MRAs, there are studies that have shown that MRAs have shown beneficial findings in those patients with MI and LV dysfunction. And this pathophysiology of the aldosterone is very complex. It's not coronary restoration. It's a lot of pleiotropic effects that showed beneficial findings. We now have new medications that have beneficial impact on classical heart failure patients. Whether this will be extrapolated to ICMP, we don't know. For ARNIs, this is very interesting because ARNIs had a beneficial impact in classical heart failure. It slightly had a failed impact in MI heart failure patients. However, in recurrent events, it had a beneficial effect, which made this medication one of the 4 pillars even in MI patients. SGLT2 inhibitors, some were positive, some were neutral, but this was not really a definite winner and definite loser. It was how the study was defined, what kinds of patients were included in the studies, which made the difference in the outcomes. So regarding in the optimal medical treatment in patients with a classical heart failure, we know that we have the 4 pillars. Usually this is very similar used in the ICMPs, which is obviously not related to the ischemic concept itself. So then, where is the gap? Well, first, I think that the diagnosis is very difficult. How should we define ICMP? If the patient has ischemia and a depressed LV dysfunction. Is this a ICMP? This is a very difficult finding because some ischemias are just bystanders. So then in these patients, what's the pathophysiology? Obviously, ischemia is not the only pathophysiology. It's a very complex kind of interaction leading to a LV dysfunction. How should we interpret RCTs and real-world evidence based on the various heterogeneity of patients that they enrolled is a very difficult kind of finding. This was a study that we showed, the revived PCIS trial that has failed to show the beneficial effect of PCI. Some say that the PCI has done incomplete revascularization, which led to a negative finding. But regarding the medical therapy in these patients, we could see that these patients had a largely incomplete OMT, which is probably a more concern regarding the power of OMT that we have. So it's very difficult to interpret previous results in regards of the beneficial effect of ICMP, of medical therapy for ICMP. So regarding, this is the conclusion, and medical therapy obviously is a must-do in treating ICMPs, and regardless of any kind of other antiplatelets and lipid-lowering therapies, we have traditional medications for heart failure. So, and this is because ischemic cardiomyopathy is not only ischemic, it's more a cardiomyopathy. And also because of this complex kind of disease entity, it's very difficult to interpret previous RCTs, but still there is a beneficial impact in medications that we use, and still OMT is essential over revascularization. Thank you for your attention.
Thank you for your lecture. Now we'll have panel discussion and question and answers from the floor, but time is very limited. We have only 12 minutes, so I'd like to ask for brief question and comment. So now is the panel discussion. Who will start first?
Hi, I have a question for our first speaker about the Japan registry in Impella.
Okay.
I noticed that the mortality benefit was survival was 80% in the registry with Impella support. That's really remarkable. Looking at the danger trial from the trial data is only about 60%, 65%. So obviously this in the real world in Japan that did really well. Is there any reason why you can share with us how the data, such good results?
That's an extremely good question. That's again, that's a 30-day mortality, so which is different from 180-day mortality in danger shock trial. And those are the initial experience with the Impella use in Japan. So I think there could be potentially be an patient selection. Maybe the operators used Impella for slightly, less morbid patients. But data are data, so it's published.
Yeah, and can you also share with us, some of us will go down the path of unloading the LV before revascularize. And in Japan, what's the practice at the moment?
Yes, use of Impella before revascularization is advocated, but I think about 60% of the patient received Impella before PCI in that registry.
Can I also have a question to Dr. Ako? I think the outcome of the cardiogenic shock, despite treatment, is actually really depends on the pre-existing LV function. For example, for patients who had come to the hospital very late and with very profound LV dysfunction, no matter what you did, perhaps do not do any good to patient. I would ask you a question. What's the average D2B time for AMI patients in Japan?
It's D2B. Yes, it's less than 90 minutes usually for STEM patients.
Wow, amazing! Thank you.
I have a question to Joo Myung Lee, and I would like to thank you for your wonderful plan for ICMP. And is enrollment going well with your study first? And I also would like to ask, is the cutoff of 0.75 or 0.80 also applied for the ICM as well?
Yes, the enrollment, we already enrolled about 100 patients, and the target number is 900 patients. So we need more time to complete enrollment, and we are using 0.80 as a cutoff value because in LV dysfunction patient, elevated end diastolic pressure, which usually the FFR can underestimate lesion severity. So we use conventional cutoff value. Thank you.
What is your strategy for CTOs in the trial?
Yeah, CTO, in the trial protocol, the major vessel CTO, meaning the very large territory of the myocardium and risk, for example, the proximal to middle LAD and proximal suck, and the dominant RCAs proximal to distal RCA CTO, we strongly recommend the best revascularization for the CTO lesion. And if that CTO procedure is failed, we also recommend bailout bypass surgery if that CTO is major vessel CTO. Thank you.
Sorry. Yeah, thank you. It's been a great number of presentations. But just to make a comment, if you look at what happened in the ischemia trial, there was a benefit of CABG, but not in the REVIVE trial. The mechanism may be totally different from impaired ventricular function. The benefit of bypass grafting, it didn't appear for 5 years and then accelerated past 10 years, is probably because what it's doing is reducing the effects of subsequent proximal coronary disease. If you stent the patients, you don't get that benefit. It may deal with a localized proximal lesion, but it offers no prophylaxis against future disease. The probable and the most likely mechanism of the survival benefit in ischemia is by having bypass grafts that cumulative proximal disease no longer has an effect. And that's particularly important if you already have impaired ventricular function. If you've got a normal EF and you take a hit with a myocardial infarction, you can probably survive that because you've got essentially had well-preserved LV function. If you have a myocardial infarction where you already have impaired LV function, that probably has a much greater pathophysiological effect. Just a thought. Thank you.
Yeah. In response to that, Dr. David, so does it change your practice if you know anatomically a patient with triple vessel disease with a left main and a non-viable LAD region because of post-MI? Do you not do a viability study first? And because you said that there's still benefit in CABG rather than PCI. If it's PCI, if you ask us, if it's non-viable, we won't open up. We just open out the culprit vessels. The other two is multi-vessel, yeah.
I think the important thing is in the STITCH trial, both ischemia testing and viability tests had no prognostic effect on the survival benefit of a CABG operation. And that's entirely consistent with the SYNTAX trial, where patients benefit, their determination of a CABG operation was on visual level of angiographic stenosis. There was no FFR. And interestingly, if you look at FAME3 where there is FFR, it made no benefit. CABG was still significantly better. So CABG is doing something that stenting doesn't. And we've known that for 2 decades or 3 decades. So I think the key point to take away here is if you have a patient with impaired ventricular function and significant 3-vessel angiographic disease, you should not be turning that patient down for a CABG operation on the basis of ischemia or viability testing. You may wish to do those because they may give you some kind of comfort, but you should not be turning patients down from a CABG operation on the basis of those tests. Thank you.
Thank you. David, Dimitri Krampaliotis, we debated this like pre-COVID, right? So just get me the surgeon that was going to operate on these patients.
Send them to me.
I will put them on a Learjet and fly them directly to to Oxford, right?
Please.
Yes, but the truth of the matter is that nowadays surgeons shy away from these cases. Now, for them, in all seriousness, all joking aside, Dave and I have been going back and forth since the Excel trial and all these things, but. The viability issue, I think, is going to be answered as far as PCI is concerned with the PROTECT 4. The PROTECT 4 trial is a 1,200 patient study, and we have a sub-study of almost 300 patients where we're doing viability at baseline and 3 months, 6 months post. And we're blinded to the actually viability results. The STITCH trial viability, in my humble opinion, if I can be humble, is that it doesn't add much because they used very different ways of assessing viability. And so I think that stay tuned, and I think that within a few months or a year, we will know what happens with the issue of viability and PCI. And yeah, just send me your admin's number so I can send from New York all my patients to you. But you have to vow that you will not turn anybody down. Because it's easy to stand up here and say we'll operate on anybody, but I know you do, but not everybody does. Thank you.
All right. The panel want to say anything?
Can I say something about, well, because CABG versus PCI, CABG does something that PCI does not do, and you mentioned that that was probably preventing the patient from subsequent myocardial infarction or etc. Because I'm on the medical therapy field, my presentation was that, then probably the effect that PCI does not do but CABG does is the impact that medical therapy does. Can that be one of the concepts that you are having? Like, well, let's say that statin inhibits future myocardial infarction. So then PCI cannot, CABG does the effect of PCI plus statin. Is this the way that I can understand it?
Yes. Yeah. So no one who practices CABG, if you are not making sure your patients are on optimal medical therapy, you're doing the wrong job. It's absolutely unethical, apart from being bad clinical practice, to be doing operations on patients who are not on best medical therapy. But the point I'm making is if you look at every study in terms of long-term survival, CABG has a consistent benefit over PCI over every study that's ever been done, including the most recent FAME3. And FAME3 was designed to use FFR and use the best generation drug-eluting stent, because that was the criticism of the Syntax trial. And still, CABG is the best treatment. And the most likely pathophysiological mechanism is that with advanced coronary disease, it is progressive, even on optimal medical therapy. And if you have bypass grafts to the mid-coronary vessel, especially if they are arterial grafts, it means that any future proximal disease is essentially irrelevant. That doesn't happen with PCI, and that is the most likely reason why, despite 3 decades of improved technological developments in stents, it still doesn't match bypass grafts.
David, is there a period of time that you will wait before operating on somebody with LV dysfunction to optimize their GDMT?
Yeah, there are very few patients in the current generation who need to be operated on immediately. There are some, but they are a real exception to the rule. So in over 90% of patients, even when you decide that you feel bypass grafting is the best therapy for the next 10 or 20 years, the vast majority of these patients in our institution would be put on maximum medical therapy within a week. In other words, put them on it immediately, wait a week, and then do their bypass graft operations. But there are very few patients who cannot wait a week for a bypass operation.
But really, it takes months for that therapy to start to take effect.
We don't know that.
We do know it a little bit.
Well, yeah, but we don't have a time scale for that. But the point I'm making is nobody in the UK would be now undergo a bypass operation who's not put on optimal medical therapy immediately. Now, you may well be correct. Should you wait a week, a month, 6 months?
No, we wait 1 to 3 months sometimes.
Fine.
Let those drugs work.
In the UK, if they are stable patients, you can wait a couple of months. If they are acute coronary syndromes, that may be a different thing to factor into your equation. There are some patients who come in who are not on optimal medical therapy, but who have what would appear to be life-threatening coronary disease. And most of us would feel uncomfortable sending those patients home before. So you don't need to revascularize everyone immediately, but there are some you do.
Yeah, I'd have a stent in them before.
I'm sorry, you?
I'd have a stent in them before medical therapy, unless it was multivessel.
So I didn't catch what you said. You did.
I said I'd have a stent in them before they could get medical therapy.
Well, many of us in the UK would disagree.
Okay, thank you very much for a very nice discussion. In the interest of time, I have to close this session. Thank you very much for attending this interventional heart failure treatment.